Hello, hello. My name is Kirsten, and I'm a student health visitor. This talking head is going to focus on a scenario with a teenage mother called Katie, who's 15 years old, and her son Matthew, who's 14 days old. In this scenario, I've gone to do a home visit to complete Matthew's new birth mandated contact. Katie's currently living with her mum and brother. She's split up from the father, of whom we have no details for. Katie is currently combi feeding and complaining of breast pain. It's not clear from the scenario if Katie had an antenatal health visiting contact, so after being invited into the home, I introduced myself and explained that I was a qualified nurse undertaking my health visiting training. I made sure that I had used alcohol gel to decontaminate my hands as per infection control policy. I gave them a bit of an overview of what the health visiting service entails. I explained the purpose of today's visit was to check on Katie and Matthew's well-being and offer support as required. I explained that I would need to make an assessment of both their health needs and that I would look at all the factors that could impact on their health. I received Katie's consent to do this. I also asked Katie if she wanted her mother to be present during this visit or not. The first part of the assessment was to ensure that Katie is Gaelic competent and therefore able to make decisions about her and Matthew's health. Due to the fact that she is 15 years old, legally she can only consent to healthcare if she has Gaelic competency. Whilst it may have been documented in her hospital or midwifery notes, we may not necessarily have access to these, so I would need to make my own assessment. In order to do this, I would need to assess whether she understands the information she's been given, that she's able to retain that information long enough to base a decision, that she can weigh it up and use the information to decide and to make a decision and to communicate that decision. In reality, I'd be assessing this in an ongoing way throughout this encounter by analysing how she answers questions and communicates her concerns. In order to assess the family's needs, I utilised the Common Assessment Framework tool as it's recommended in the Healthy Child programme, which provides a framework for health visiting practice. It assesses the child's developmental needs, the parenting capacity of the parent, and the impact of wider family and environmental factors, and therefore ensures a holistic assessment for that family. It aims to ensure that families receive early intervention, something that's recognised by Public Health England as a way of improving outcomes for teenage parents. In relation to assessing Matthew's developmental needs, I completed a top to toe and also discussed feeding with mum. In terms of parenting capacity, I asked questions around mum's mental health, physical well-being, and what her childhood was like to establish if any ACEs had occurred, as well as observing for evidence of maternal warmth and good attachment. In terms of the family and environmental factors, I considered what Katie's support networks were like, if the family was financially secure, and if they'd ever had social services involvement. I also conducted a heat assessment, which is a home and environment assessment tool, to highlight if there were any concerns with housing that would need to be addressed, so for example, damp. To carry out this assessment, I used a variety of open-ended questions, so for example, how are you feeling today? How do you feel feeding is going? In order to explore how Katie was feeling and adjusting to motherhood. This would give her an opportunity to talk about the issues that were important to her. I made sure my body language demonstrated that I was interested in her concerns and valued her thoughts by making eye contact and nodding and responding to various points. By making sure Katie feels valued, this will help to build trust and develop a therapeutic relationship, and this will be essential to support Katie going forward. If Katie didn't want to reply or seemed uncomfortable with the questions, I made sure to offer a rationale as to why I had asked. So, for example, when Katie was talking about Dad and not wanting to tell us any information, I explained it would be useful to have details about Dad on Matthew's health record, as it may help us make decisions about the care Matthew needs. So, for example, it would be useful to know about Dad's ethnicity to decide whether or not Matthew needs BCG. This assessment identified a wide range of needs and indicated that Katie would require a more enhanced level of support than the Universal Health Visiting pathway. As such, I've placed her on the Universal Plus pathway and will also place her on the Local Best Start pathway. The Best Start pathway is for families where there are additional needs identified, such as teenage pregnancy. It's a joint partnership between Health Visiting Service and the School Readiness Team and provides a list of mandated visits, including joint visits that are carried out by each team. Public Health England recommend in their Supporting Young Parents framework that young parents do best when help is offered at an early stage and is coordinated between different professionals. So there were many needs identified during this assessment. Not all of these will be able to be addressed today, but will be addressed by providing ongoing support. So these needs were the lack of antenatal care and the impact this could have on Matthew's development. So, for example, missing screening and the potential that Katie drank alcohol during pregnancy because she didn't know she was pregnant. We don't know any details about Dad. Useful to know his ethnicity and medical history to assess if this could impact on Matthew. It was potentially a concealed pregnancy, so Katie might have been denying that she was pregnant. And sometimes this can indicate a lack of acceptance, which can impact on the ability to form an attachment. Katie's got issues with her mental health and has had previous anxiety. We also don't know how well she's recovering physically. We need to talk to her about this, but it sounds like she had an assisted delivery. The specific challenges Katie may experience as a teenage mum in relation to her brain development and how we can support that. There's a lack of wider support. So, for example, mum is busy dealing with a sibling who has ADHD and she doesn't see her father. There's evidence of risk-taking behaviours. So, for example, underage and unprotected sex. Are there other risk-taking behaviours that we don't know about? She'll need advice in regards to contraception. Katie is having issues with feeding, including breast and nipple pain, and feels unsupported with feeding. She's socially isolated and missing her school friends. We don't know if there was any ACEs in childhood, but we know her parents are separated, which is a potential ACE, and this may impact on her parenting. There's safeguarding concerns. For example, we don't know the age of the father. Katie is under the age of consent, and we don't know if sex was consensual. She may not be able to recognise a healthy relationship if there was a power imbalance in this relationship. And she's also potentially at risk of sexual exploitation. Despite all these areas of need, there are signs that things are going well. Katie delivered a healthy term baby of a good weight. Matthew's regained his birth weight and pooing frequently, both signs that baby's feeding well. Katie's enjoying giving Matthew cuddles, which will help develop a healthy attachment. Katie has taken an interest in how to meet her baby's needs. So, for example, she's researched whether or not to use a dummy and is already thinking about how to make sure he's vaccinated. Katie has aspirations to return to school and has been doing well academically prior to having her baby. The majority of the visit focused around ensuring the feeding issues were addressed and also taking the time to assess Katie's anxieties fully. My rationale for this is that I felt these were the two most pressing issues that, if left unaddressed, could affect the immediate safety of Katie and Matthew. So, for example, if Matthew's not feeding correctly he could become dehydrated and we'd be at risk of becoming unwell. Breastfeeding and maternal mental health are two of the 6 high impact areas from the 4-5-6 framework. So, it's very important to address these. In relation to the breastfeeding support, Public Health England recommend that involving the wider family to support teenage mothers with breastfeeding can be beneficial. So I asked, it may be useful to involve Katie's mum at this point of the visit, but only if Katie was happy with this. Katie seems to be struggling with deciding what to do for the best in regards to feeding. The choice between breastfeeding and formula feeding may spark ethical debate, as the evidence shows that breastfeeding promotes better health outcomes, so it could presume that we have an ethical obligation to promote it. However, Katie has the right to her autonomy, and therefore we should support her decisions. By pressuring a mum to breastfeed, we could potentially do more harm than good. So, for example, it may impact negatively on her mental health. We have to make sure we are working towards the principles of non-maleficence, i.e. our actions should not cause harm, and in doing so we are working towards ethical practice and working within the guidance of the NMC Code of Conduct. This is also in line with UNICEF guidance about how we should support mothers regardless of their choice to feed their baby. I used open-ended questions to determine what Katie's desires were in relation to breastfeeding. For example, does she want to exclusively breastfeed or does she want to combi feed? So that I could ensure the support I offered her reflected what she wanted. I established what Katie already knew about breastfeeding. So, for example, asking her if she was aware of the many benefits of breastfeeding. When Katie was able to tell me some facts about breastfeeding, I gave positive encouragement that she had taken an interest in this and then offered further information. By making Katie aware of the benefits of breastfeeding, she's able to make a decision about how to feed her child based on facts. This is in line with how UNICEF recommends professionals talk to mothers. I also made sure to highlight what she had accomplished so far, the fact Matthew had regained his birth weight and the fact she had now breastfed for 2 weeks. I also highlighted that despite supplementing with formula, Matthew still receives the many benefits of breastfeeding, such as the protective antibodies. One of the issues from the assessment is the pain that Katie is experiencing when feeding. I offered to complete a feeding assessment with Katie's consent, so I completed the UNICEF breastfeeding assessment tool. Examples of questions include how many wet nappies a day does the baby have and how long do feeds last. Completing this checklist together would help highlight what's going well with breastfeeding and also helps Katie recognise what the what signs of feeding going well are. This is in line with how the UNICEF Baby Friendly Initiative, where it recommends breastfeeding mothers are taught how to recognise effective feeding. I asked for consent to observe a feed in order to assess Matthew's attachment. I recognise that Katie might feel uncomfortable with this, as she has disclosed she is feeling embarrassed about feeding in public. I explained that it would be the most effective way to assess his attachment, and as poor attachment is often the most likely reason for pain, this is the best way for me to help her. I utilised the CHINS acronym as a tool to demonstrate effective positioning. I checked that Katie held Matthew close to her, that his head was free in order to allow his chin to lead when attaching to the breast, that his head and body are in line to ensure he's not twisting his head to drink, that the nipple was positioned below Matthew's nose so that when he attaches to the nipple, when he attaches, the nipple is not rubbing it against the hard part of the palate, and that the position was sustainable. So, for example, is it comfortable enough to last a full feed? I signposted Katie to the Start for Life website as it contains useful evidence-based information in relation to breastfeeding, including a video that she could watch on attachment. UNICEF also recommends that all moms are taught how to express milk and the benefits of this. This would be beneficial for Katie as she could express breast milk and apply some to her sore nipples. If the pain of breastfeeding is too much for her to endure, she could also express and offer the feed in a bottle. If the pain is related to breast engorgement, it may be useful to express a small amount prior to each feed, as sometimes babies can struggle to latch onto an engorged breast. And if the baby struggles to latch, then that will also exacerbate the pain. I also talked to Katie about the supply and demand cycle of breastfeed, and then if the breast isn't stimulated either by Matthew or expressing, her supply will dry up. I taught Katie through the process of expressing using a visual aid. To start with, she should make sure she is relaxed and then start by massaging the breast. I explained that she would need to make a C shape with her hand like this in order on either side of the nipple, about 2 to 3 centimeters away from the nipple. I then explained that she should squeeze down for a few seconds, then release. Milk might not appear straight away, so she might have to try a few times. I then explained that she should catch the milk in a sterile bottle. Once the milk no longer flows, then she should keep her fingers in the same C shape and move to a different part of the breast and repeat the process. I reassured her that even if she can only express a small amount, that's okay, as Matthew's tummy is still very small. I offered her the opportunity to try expressing whilst I was with her, but reassured her there was no pressure for her to do this. I finally explained to her that milk could be kept in the back of the fridge for 7 days or in the freezer for 6 months. As Katie has also been topping up with formula, it was necessary to discuss bottle feeding. I asked Katie how she was making up the feeds to ensure she was using the correct technique. I talked through how to make up formula feeds. So I made sure that she was making the feeds by boiling a litre of fresh water, by making sure that she cleaned her hands and the preparation counter. She then needs to fill the bottle with the desired amount of water, add the correct number of scoops using the scoop that comes with the formula, and then shake the bottle well to get rid of any lumps. To cool the bottle, she needs to run the bottle under cool water to get it to the correct temperature. Unused feeds must be discarded within 2 hours. This is in keeping with the NHS guidelines. By ensuring she uses the correct technique, this reduces the risk of infection due to the potential presence of bacteria in the powder, and therefore this reduces the harm to Matthew. I made sure she was sterilising the bottle correctly depending on the equipment she had available, so for example a steam steriliser. We also discussed responsive feeding, so for example allowing Matthew to draw the teat into his mouth, and paced feeding, so giving Matthew a chance to take breaks throughout the feed. This reduces the chances of him being overfed. We discussed the need to limit the number of people feeding Matthew to help him feel secure and promote the development of a healthy attachment. I explained that looking into Matthew's eyes while he feeds can also help this. Finally, in line with UNICEF guidelines, all mothers should be given advice on how to care for the baby at night. I asked Katie how she was coping with nighttime feeds and gave suggestions as how she could make things easier for herself, such as lying down to feed or making sure she has all the bottle equipment ready before bed. She had already disclosed that she was finding the nights hard, so I gave her opportunity to talk about this. I also linked this conversation to safe sleep. I asked Katie to show me where Matthew sleeps to ensure it met with safe sleep requirements. I discussed the principles of safe sleep with Katie, such as placing one's back to sleep, never using pillows or wedges, and keeping the room at an appropriate temperature. As per NICE guidelines, it's important to highlight the risk between co-sleeping and SIDS, and I made sure to tell Katie about this, as well as the risk of falling asleep with Matthew in a sofa or a chair. I signposted her to the Lullaby Trust with particular reference to Little Lullaby, which is aimed at young parents and is all evidence-based information. Being a teenage mum means Matthew is at an increased risk of SIDS, so it's essential that we discuss safe sleep at this visit and at every visit in the future. In regards to the dummy, I'd praise Katie for taking time to research what she should do. I have signposted her to the Baby Buddy app and Start for Life as a source for reliable information, so as not to be overwhelmed by information on Google. I've explained that using a dummy might cause nipple confusion and might reduce Matthew's ability to latch effectively. I've highlighted that Matthew is already having difficulties latching. It may not be beneficial to use one at this time. Ideally, it would be better to wait until they're both more comfortable with breastfeeding, usually after 1 month. If Katie decides to use a dummy, I'd make sure she knows not to take it away until Matthew is 26 weeks as per NICE guidelines. I've reassured Katie that Matthew might be crying for reasons that are not related to hunger and that this is perfectly normal. I've given her advice on how to soothe a crying infant, so for example cuddling him or winding him, and that at this stage babies like to be close to their mothers. I've explained how this is beneficial to Matthew's brain development and that it is okay to hold him. frequently, as this will develop a bond with baby. I point this will help build a healthy attachment. Sorry, this is in line with the guidance UNICEF gives in developing a bond with baby. I pointed out how well she was doing, picking Matthew up for cuddles in the day. Developing a healthy attachment will benefit Matthew's development going forward. And as the first 2001 days are crucial for his development, it's essential that we give Katie the support to understand how to strengthen this attachment. I also discussed normal infant crying and explaining that it is normal for infants to cry using the icon tool. We discussed techniques for coping if Matthew's crying gets too much for her, such as putting him in his cot while she calms down, but also explained that it's never okay to shake a baby. Moving on, it's trust policy to conduct a top-to-toe assessment of newborns between 10 to 14 days. I looked over Matthew from top to toe to look for any abnormalities. In relation to feeding, I was able to assess Matthew's colour. So, for example, if he appeared jaundice, this might indicate that there was a feeding issue. I also checked for a tongue tie, which can cause attachment issues. So it's important to rule this out. And also looked for any signs of thrush. Thrush can be passed between baby and mum and can cause breast pain, so it's important to rule this out. I also utilised the principles of making every contact count by discussing how to care for a newborn skin. So, for example, not using perfume products. I related this to Katie's concerns related to bathing and reassured her it's perfectly okay not to bath a baby every day. Finally, I reviewed when Matthew had last been weighed by the midwife, and if it hadn't been done in the last day, I weighed him and plotted the weight on his growth chart to ensure Matthew was gaining weight as expected. Weight loss or no weight gain may suggest a feeding issue and would need to be addressed. Moving on to Katie's health, I gave her the opportunity to discuss her anxiety. From her presentation, she was tearful and asking a lot of questions, which suggested she may be suffering from anxiety, particularly as she has had this in the past. I offered to make an assessment of her mental health using the GAD tool and the Hooley questions, as these are evidence-based tools that are recommended by NICE. These highlighted Katie would need further support. I've offered listening visits and have signposted her to local mental health support services. Katie also appears to lack in confidence with her parenting. So, for example, she says she doesn't know what to do, or she feels unsure what to do when the bottle doesn't settle in. This could be down to lack of antenatal care and opportunity to attend parenting classes. The advice that I've given around infant crying and developing attachment may help her with this. I've also offered to complete an MBO at a different visit so Katie can gain an understanding of normal baby behaviour and how to respond to Matthew's cues. The PHA, the Public Health England, have developed a framework for supporting young parents where it states that parenting capacity is the biggest factor that can impact on a child's well-being. So it's important to give Katie the tools to parent well in order to meet Matthew's needs. It is important to recognise the specific challenges of meeting Katie's needs as a young mum. As a teenager, her brain is physiologically wired differently than adults. Teenagers often struggle to process emotions and recognise other people's emotions. It can be challenging to regulate their own emotions without the added difficulty of recognising and meeting the needs of a newborn. As such, teenagers can sometimes struggle to adjust to parenthood, and this can impact on parenting capacity. The first 2001 days is a crucial time for Matthew's development, so it's important we provide Katie with the correct support. The Solihull approach recognises the difficulties teenage mothers have, so it may be worth referring her to a Solihull parenting class. Katie's also mentioned she found the birth quite difficult, so it's important to identify if she is suffering from any psychological trauma from this. I've offered Katie a chance to talk about the birth and offered to refer her to a birth debrief if necessary. We also discussed her physical well-being. She is still recovering from a difficult delivery, so I discussed pain management with her. We also discussed the importance of looking after her own physical health, including diet and exercise. I utilised the concept of making every contact count and used the 3 A's approach to discuss multivitamins. First of all, I asked if she'd ever heard about the benefits of taking a multivitamin. I then gave her advice on the benefits of these and what options are available. Finally, the action I took was that I offered to refer Katie to Healthy Start so she could receive free vitamins. I would also address the level of support Katie has at home and in the wider community. I would offer to speak to her mother and see if there is any support that can be put in place to assist with her brother. It may be that the whole family would benefit from a referral to early help. Katie is clearly missing her school friends and is at risk of being socially isolated, which would not be beneficial to her mental health. I explained to Katie that there were groups in the community she could access for support, including the baby clinic, and this would give her a chance to meet new mums. I offered to find information about specific groups aimed at teenage mothers. I gave Katie a leaflet with the details of these groups. I also offered her a leaflet with information around vaccination and offered to explain this in more detail at the next visit. I felt I was at risk of overwhelming Katie with information, so I decided to discuss these at the next visit. Vaccination plays an important role in making sure Matthew stays healthy, so I want to ensure that Katie is able to absorb that information appropriately. Giving her a leaflet, however, means she can access reliable, accurate information if she chooses to do so before our next visit. And because I plan on visiting her again in a week and not at the 6 to 8 week check, we have time to discuss that before the vaccination schedule starts. I've made a plan with Katie to address some of the issues that were raised during the assessment. I've explained to Katie that I'll visit her in 1 week, and will continue to visit her on a regular basis. We made a clear plan of how to address her breast pain, to start expressing and to work on positioning using the CHINS acronym. I reiterated this advice at the end of the visit and also got Katie to relay it back to me so I knew that she had understood it. Before I left, I checked Katie had the correct details for the health visiting, correct contact details for the health visiting service written in her red book, and I made sure that she knew she could contact us at any time. I am mindful that Katie was in quite an emotional place today and also quite tired. I tried to limit overloading her with information, which is why we focused on key safety points such as icon and safe sleep and addressing the feeding issues. As I plan to visit her again in 1 week, I will reiterate this information again, as well as offering her new advice. So, for example, advice around the immunization schedule or contraceptive advice. There are many needs that need to be addressed in the future. For example, Katie may benefit from some advice and support about how to recognize healthy relationships. However, this can be addressed once initial issues relating to feeding have settled down. It may be that she discloses further information about the father, or she may disclose that she was raped, and therefore I would support and offer signposts to relevant agencies as needed. In light of some of the safeguarding issues, I would discuss the family with the local safeguarding nurses for advice. These issues are the fact that we do not know who the father is and the fact that she is 15 years old, which has legal implications. She is potentially at risk of sexual exploitation. The T's safeguarding policy for concealed pregnancy states that a mother should be referred to social care if the pregnancy is concealed until delivery. As this was not the case in this situation, I have not put in an automatic safer for Katie, but I would be mindful of making sure that the correct support was put in place for Katie as per PHE guidelines. It's likely that Katie will need support from a variety of professionals going forward. I would also liaise with the school nurse about how we can support Katie's interest in returning to school and perhaps remain involved with the school counsellor. Afterwards, I documented the encounter on System 1. I made sure Katie was aware that we share information between professionals and that had received consent to do so. So, moving on to the questions. Question 1. The need I'm going to focus on for this question is breastfeeding and how we can encourage Katie to continue breastfeeding despite the issues she is having. I've already discussed the specific advice that I would give, which is based around the UNICEF baby-friendly standards. I would utilise motivational interviewing to try and encourage Katie to breastfeed, as it is an evidence-based method to promote behaviour change. Breastfeeding is associated with improved health outcomes, so it's important to try and encourage this behaviour in a way that doesn't make Katie feel pressured. I utilised the rule tool to help structure my contact with Katie. I resisted the writing reflex whereby I didn't tell her what to do, so I didn't tell her to stop giving formula, but instead I tried to understand her own motivations around breastfeeding. I used open-ended questions to give Katie an opportunity to discuss how she felt, which strengthened my understanding. I made sure to listen with empathy, which I displayed through non-verbal cues, so for example, engaging in eye contact. And I used reflective listening techniques whereby I repeated back to Katie what she had said. So for example, I can see that you are finding night feeds difficult. This gave her an opportunity to expand on that, but also made her see that she was being understood. Finally, I empowered her by recognizing the positive steps she'd already taken and encouraging her desire to continue breastfeeding. It is important to recognize that motivational interviewing is not a simple technique where we can carry out an action and expect a desired outcome. It does have its limitations because there needs to be that desire for change from the service user before professionals can support this change. But equally, because it's based around the service user's own motivation, it's an effective way of promoting behaviour change. Moving on to question 2. SCPHN practice revolves around identifying areas of need to improve the health of an individual or population and how to address those needs. This part of our role is laid out in the SCPHN proficiencies. It may be out with our own area of expertise to address those needs, so for example, they may require the support of a social worker, and therefore we need to refer to the appropriate professionals to meet those needs. The Healthy Child Programme highlights the importance of identifying need early. However, it is only beneficial if we can implement the correct support for families. In order to do this, we must work with other professionals and work towards shared goals that will support the family. In relation to Katie, the PHE emphasises the importance of multi-agency working in their framework for supporting young families. It is also particularly relevant when working in safeguarding. Working together to safeguard children highlights the needs for professionals to work together by sharing information and ensuring professionals work towards shared goals that will protect children from harm. The NSPCC highlighted some of the key learning points from serious case reviews. These include professionals not sharing information appropriately between different agencies and professionals not working together effectively. Teenage mums are a high risk group for being involved in serious case reviews, so the need to work together well is crucial to prevent Katie from escalating to safeguarding concerns. Question 3. SCPHN practitioners are public health nurses for whom one of the key parts of their role is to reduce health inequalities. These are differences in health between different groups or populations. This is important to bear in mind when working with Katie because teenage mothers are more likely to experience health inequalities. So, for example, they're more likely to smoke during pregnancy, more likely to suffer postnatal depression, less likely to breastfeed, and more likely to live in poverty, which in turn increases the chances of ill health. PHA has developed a framework to support teenage parents and recommend that support is early, sustained, multi-agency, and led by a lead professional. Due to the fact SCPHNs are a universal service, they are in an ideal position to offer early support by the fact they see these mothers at an early stage and are able to offer sustained visits. Through screening, they can highlight which families need additional support and make sure they are referred to the appropriate service and continue to work alongside those services to meet Katie's needs. The SCPHN has a legal opportunity to promote equality. This is laid out in the Equality Act 2010, whereby professionals have a need to eliminate discrimination and promote equal opportunities. Regardless of what needs are identified in this visit, Katie has the right to access effective services that will meet her and her child's needs. Professionals should not hold on to any preconceptions when working with teenage parents. As per the NMC Code of Conduct, I should avoid making assumptions about Katie. For example, it should not be assumed that just because she's a teenage mother, that just because teenage mums are less likely to breastfeed does not mean that Katie won't be able to. We should offer the same information that we would give to all the parents and refer to the same services, so for example, the infant feeding coordinator. We should recognise Katie as an individual and recognise what would work best for her and Matthew. For example, due to her young age and her anxiety, Katie may not feel comfortable attending a breastfeeding support group, so therefore we should recognise that and offer support in a way that will work for her, so for example, one-to-one support at home. Teenage brains are still developing, in particular the part of the brain that deals with memory and organisational skills. So it's important to be flexible when working with Katie, and I may be required to repeat advice several times over several different visits. This is important when trying to work towards equality, as equality does not mean treating all of our patients in the same way. It means working in a way that means they will achieve the best outcomes by adjusting our practice to support them as individuals. And finally, question 4. The professional considerations relating to record keeping are laid out in the NMC Code of Conduct. As a registered nurse, I would have a duty to ensure I keep clear and accurate records in relation to my practice. I can ensure this happens by updating the patient records in a timely fashion. Trust policy states this should be no more than 24 hours. I must record the events of the visit as accurately as I can and ensure what I include is factual, not my own opinion. I need to take responsibility for the security of the notes by not sharing usernames or passwords with other people. As I had travelled from the home visit to the office, I ensured that any notes I took, so for example, details of his weight, didn't have any confidential information on it, so for example, his name or Katie's full name, just in case the notes went missing. I ensured that ensuring that the records are secure and accurate means that the practitioner is working within the requirements of the Data Protection Act 2018. I need to uphold the patient's right to confidentiality by ensuring I work towards maintaining the Caldecott principles, which include only sharing confidential information when necessary. Ideally, we should only share confidential information with the patient's consent. However, sometimes this may not be possible, so for example, during a safeguarding concern. Our notes are shared between other professionals, including the GP, and I made sure to get Katie's consent for this.